Welcome everybody to this SCAI clinical conversations. We're going to be talking about a paper that just got published in JSCAI, and the title is Healthcare Disparities in Congenital Cardiology, Considerations Through the Lens of an Interventional Cardiologist. So welcome to the panel and welcome to the viewers of this conversation. We have a nice panel here, and I'm going to introduce myself. I'm going to have everyone introduce themselves. My name is Frank Ng. I'm Chief of the Division of Pediatric Cardiology at UC Davis up in Sacramento.
Hello, everyone. I'm Ivory Crittendon. I'm a pediatric and adult congenital interventional cardiologist at Ochsner Hospital for Children in New Orleans, Louisiana. I'm also the director of the catheterization lab.
Hi, everyone. I'm Howaida El-Said. I'm the pediatric interventional cardiologist. I'm the director of the cath lab at Rady Children's Hospital here in San Diego, California.
And hello, I'm Holly Bauser-Heaton. I'm one of the congenital interventionalists at Children's Healthcare of Atlanta here in Atlanta, Georgia.
Great. So with that, we're going to go into the session. I'm going to have Holly, who is the first author for this paper, give us a summary of the paper and the findings. And I'm going to launch into a quick discussion with panel's comments and thoughts on the paper.
So first, I just want to acknowledge the other authors on this paper. We had quite a group that came together from the Congenital Heart Disease Council, and this was brought together by Dr. Grimes as her presidential goal was to bring forth some of the disparities in cardiology. It was wonderful to be a part of this group, and I just thank the other authors who are not with us today. In this paper, we identified several factors that increase disparities in congenital cardiology. Certainly, there are more than what we've identified here in this schematic, but these are some that we consider quite important. Those are prematurity, differences in complexity and risk, prenatal diagnoses, treating orphan disease, which we'll speak on a little bit more and not highlighted as much in this paper, insurance for chronic pediatric patients, and distance from the interventional center. Fewer congenital centers exist compared to adults, of course, and 8 states have no interventional congenital heart disease program in our country. 14 states have a single program, and as you could imagine, being a part of one of these states presents its own challenges in terms of distance to the center. So access for emergent interventional procedures are more profound in several instances, including an infant with intact atrial septum, shunt-dependent pulmonary blood flow. And the data reveals that access to specialized care does in fact improve survival. This, of course, would take into account those rural centers who are far from the even states that have a CHD program. And further evaluation is certainly necessary to determine if increased distance from center really does result in disparate care. We know that low birth weight infants with congenital heart disease carry a higher risk, and prematurity occurs, unfortunately, continues to occur disproportionately in non-Hispanic Blacks in the order of 2 to 2.5 fold, and that increases risk of disparities in that population. We also know that there's increased low birth weight in lower socioeconomic classes in all races, and low birth weight is an independent risk factor for all major adverse events in cardiac catheterization. We know that those infants less than 2 kilograms have significantly greater risk of death during procedures. There's increased need for transfusions. There's obvious increased risk for arterial injury and subsequent need for therapy. And complications have been reported in PDA closures less than 1.5 kilograms up to 26%, with a major adverse rate of 8%. So these patients all carry high risk as they come to our cath lab. In addition, we know that prenatal diagnoses have wide variations across regions and states, and lower socioeconomic classes and those with public insurance are less likely to be given a prenatal diagnosis, and that's regardless of race. As we think about those patients who are complex and critically ill, that of course increases their risk as they come to the cath lab for interventions. We know that there is live birth disparities in complexity, and I want to highlight the live birth disparities. Of course, we're looking at patients who have survived to birth, and so we are not taking into account those individuals who have opted for termination during pregnancy. As much as 50% higher in non-Hispanic Blacks and Asians in terms of complexity. We're talking about those high-risk left-sided lesions. This puts these individuals at higher risk for morbidity for procedures. And in addition, those procedures are higher risk by nature. We have scoring systems that attempt to predict risk of cases, and we've seen that through the C3PO work. And some of these scoring systems may help us in understanding some of these complexities. At this time, we've not delineated that by race or socioeconomic class. As we think about those individuals and the distance from center or access to center, we know that that carries individual risk. So knowing baseline severity of disease is important, and it is disparate. Interventional procedures in this population have increased morbidity, if not mortality. In terms of insurance type, our data is very sparse as it accounts to congenital outcomes. Studies have shown, though, that private insurance carriers have improved mortality rates up to 3 times. And suboptimal access to care results in later subspecialty referral, meaning to our cardiology colleagues, and increased rates of readmission. So in conclusion, our group found these to be true, that healthcare disparities do, of course, exist among patients in congenital interventional cardiology. And while at this stage, we see a decrease in congenital heart disease mortality, non-Hispanic Blacks continue to have disparate outcomes as it pertains to survival. A congenital interventional team is needed, and we have to increase advocacy and institute meaningful changes for our patients. With that, I'll go back to discussion with Dr. Ng and the rest of the panel.
Well, thank you for that summary, Holly. This is great. I actually think this paper is very timely since disparities is a big topic in our country. So let me just throw out a question for some comments and thoughts. Well, what do you think about this paper? Do you agree, disagree? Why? What do you think, Ivory or Howaida?
I think that this paper, like you said, is very timely. Of course, I agree with it because I'm one of the authors, but I think it does highlight that the disparity is multifactorial. I don't think it's one thing. And sometimes when we think about disparity, we think it's because a patient is a certain race or has a certain religion or has a different insurance, that they're treated differently when they come to the hospital. But I have to say that that's not necessarily been my experience. I think we have to differentiate how we think about this. I think that there are certain populations that they are at risk by themselves, by mainly their low socioeconomic is the main thing, because the low socioeconomic makes you not able to get prenatal care, not be able to, probably not living next to a big hospital where you can get care, not be knowledgeable of that you could possibly terminate this pregnancy if you have a very, sick patient. So in Europe, for example, I don't know the data, but I know that they have a higher incidence of terminating pregnancies where babies are less likely to have these extremely complex anomalies. And that's not something that, we see here as often. So just to give you a little bit of background, I'm Egyptian. I actually trained in Egypt. I did medical school in Egypt, and then I came here and did my residency and fellowship. So I've seen the different, aspects of how the patients present. And coming from there, I haven't felt that the discrepancy is from patient care. I think the patients, once they arrive in the right facility, they get exactly the same care. But the other thing I think that's important is the family advocating for their baby. So in a very sophisticated family with high socioeconomics, they happen to be more knowledgeable. They are going to be advocates for their child, meaning that they might say, hey, I want to go, I might want to go to another center to get a different kind of care. Now, if a family does not have that background, they're not going to be able to navigate the system just as well. So that's just my thought on that.
Yeah, I appreciate your comments, and I do agree with some of your comments, although I think, this topic is immense. And I think, this is kind of like the little iceberg sticking out of the top of the water, and underneath is a behemoth. And I think it's really hard to address all the disparities with a broad brushstroke, because there are so many different elements, and some of those elements are based on sort of cities and states at which you live, the cultures, the Southern culture, the Northern culture. I mean, there's a lot of other things that go into play, but I do think that it's painful to admit, but I do also think that there are a lot of people that experience healthcare inequities based on race. And it sometimes has nothing to do with their socioeconomic class. And I think if you look at sort of the mortality rates of African-American women, you can see there's a clear difference, and it's not always associated to socioeconomic class. And I think people have highlighted that in a number of articles. And so I think that you also have to bring that in the light. And I say that as an African-American. And so, I can admit that, that people may think that there's some bias there, but I think it's well delineated in the literature. And so I do think there are many factors that play into healthcare inequity. And also, like you said, physicians. I don't think there's enough diversity. And for some people, that's important. And I think some people will shy away from the healthcare community for a number of reasons. Some of it is fear. Some of it is, I'm not sure if this person will understand me or understand where I come from. I have a number of patients that come to me and say, I go, well, how did you get here? And they go, well, I looked up cardiologists and I found you because you look like me. And I feel like I can trust you. So I do think that matters too. And so it's complicated. And I do think socioeconomic class, education, the resource allocation also is immensely important. I think pediatrics in general has a lot less resources allocated to it than the adult cardiology world. And I think Dr. Ng mentioned that earlier. It's, you can go anywhere and have a STEMI and they have interventional cardiologists. But if you're like, for instance, let's just say I live in New Orleans. Baton Rouge is the capital. Okay. And if you have a STEMI, there's a lot of adult interventionalists that can care for you in Baton Rouge. But if you're a baby born with transpo with a restrictive atrial septum and you need to have a septostomy, guess what? There's no pediatric interventional cardiologist in Baton Rouge, and that's the capital of the state. So I do think that has a lot. That's important also to address that as far as resource allocation in pediatrics.
You guys are spot on some of the thoughts. I have to say, on a personal level, I don't think the disparities is going to be on the individuals or even within the institutions. I can tell you personally that when I see a patient in clinic, I don't know what insurance they have. I just treat them. And I think that when the babies are in the hospitals, you treat them the same way no matter what. The disparities are probably more systemic. It's going to come down to whether the patient can even get to the hospital. Both of you guys alluded to some of that, right? Not only is it a socioeconomic thing, just how far you live from a center can impact it. I know that personally, I have this one baby that has total veins, just had it repaired, recurrent pulmonary vein stenosis. I put stents into them. He's went through Avastin, Gleevec, and there are multiple times where they couldn't come back to visit us because they either didn't have a car or a ride, or they didn't even have a cell phone. Now, again, I don't think this has to do with the providers and the care. It's really much more systemic that you guys have alluded to. One of the things I do want to bring up, and we talk about disparities on healthcare delivery as the focus on this paper, but there are disparities even in the providers. And what I mean by that is, if you look at what we do as interventionists, the number of procedures we do, for example, the CPT codes for those are way less than what the adults have for what they do. Now, granted, we're not talking about salaries and reimbursements for us, but I think that even in that scenario, you have a differential in reimbursements and valuations for the work that impacts the institutions that gets reimbursed. So therefore, you don't have a lot of resources within the pediatric cardiology community to even be able to build institutions, build a place where you can have more care. Again, I think that goes along, it sort of is consistent with some of the reasons why we don't have as many centers available to take care of kids with congenital disease, because just less resources. And at the end of the day, it's going to be the dollar that allows you to be able to develop programs and so forth. That's why I think that disparities, as you said, Ivory, is much more immense and complex. And It's going to come down to the resources we can get to help our patients. But what do you guys think of that? And I know that you guys have jumped onto some of the personal experiences. Holly, what are your thoughts in Atlanta? You know, we have representations from multiple states here. You have Louisiana, California, and Georgia. And what are your comments from the South?
I think Ivory hit on something very important, and that's the culture that's different amongst various regions. I think the trust that folks have in maybe physicians who don't exactly look like them can be different. I think the patient alliance can be a little different as well. One thing that we cannot address in this paper that I think is something that should be highlighted is, are we offering complex, high-risk procedures in the same fashion to everybody in the same way? And I think that all of us need to be very thoughtful and honest about when a family is their bedside day in and day out because they have the resources to do so. It appears very different to the provider about how they can care for their child versus somebody who might have other children at home and are working 2 or 3 or 4 jobs to try to maintain that household. And the reason they may not be present is because they cannot be. I think that's something that we have to be thoughtful about. How many times have we sat through some sort of discussion and we say, well, the family's never here. We don't know if they're really dedicated, when in reality, they're very dedicated. They just can't be here for economic reasons or social reasons, just because they don't have the support system. So I do think that there's multiple factors, and I see that here in Atlanta. Our population does come from quite a ways. We're the only children's heart center really in the state, and so the travel distance is great, and there's a lot of resource poor areas in our state that require families to be away from the bedside.
I think that Ivory really hit it, the nail on the head. One of the biggest problems, like you're saying too, Holly, patients are traveling a long distance. So if you have a patient with transposition of the great arteries where their survival is dependent on having a good atrial communication, if it's going to take them 3-4 hours to get to a center, by that time they're going to have had some further brain damage. And so and also what makes it more difficult is those patients are actually sometimes hard to diagnose, even if they've had prenatal care by their obstetrician. So I think that's a really important example. I think the other really important one that you alluded to, Holly, in the paper is the adult congenital population. I think that one is really suffering from this disparity, because those patients, if they don't have insurance, they actually cannot be seen. Then they have to come to the emergency center, and they're in really bad shape. So regular follow-up for those adult congenital patients is not available, and a lot of them do not have insurance. And so I think that's something that we really need to address. And I think our adult colleagues need to help us with that. And because, as Frank is saying, the adult cardiology world does get more funding. Somehow they are able to get more funding, whether it's from philanthropy or other things. And then these patients just fall on their laps, and they're like, what do I do this patient? And they usually fall on their laps when they haven't been able to have good and adequate care.
Frank, I think you and Howaida, I think you guys hit on something that's extremely important is reimbursement. And I do think that has a lot to do. So there's a very elegant paper that many of you may have read in the Journal of Pediatrics talking about RVU production in pediatric interventional cardiology. And it sort of goes through in an elegant fashion how the reimbursement rates for these complex right heart caths and the stress induced by those kind of procedures, are sort of equated to a right heart cath in adult. And all of us who do interventional cardiology and congenital heart disease know that it can be extremely complicated to cath a single ventricle heterotaxy and to do a quote unquote right heart cath. And I do think so that's one issue. And I think because there's not a lot of reimbursement associated with that, I do think we lack resources. Also think adults are way more effective as far as advocacy. They have a lot of groups that do a lot of advocacy and sort of provide external support for their programs. And I just don't think that we often, as a sort of smaller community, do that very well. And then that reason, I don't think we reach as many patients as we could that have complex congenital heart disease, whether we're getting them seen for prenatal visits or whether we get out there in the community and just raise awareness of congenital heart disease. And I think you also hit on a huge topic, which we can spend hours talking about, the adult congenital population. There are so many people lost in the adult congenital world who just have no clue that they need to be seen in an adult congenital center. And that does create huge health inequities. And those patients often show up quite sick, quite ill, and they had no idea they needed to be seen. So I do think those things are also important.
Well, I know that we acknowledge that there are disparities in congenital heart disease, but as both Howaida and Ivory alluded to, when it comes to the adult congenital heart, not only are those the same disparities exist in that population, but then it comes down to the insurability. I know that in California, right? If you're a child and you have congenital disease, no matter whether you have insurance or not, there is a state insurance, CCS, the California Children's Services can provide that insurance. And then, but once they hit 18, that insurance goes away. And I know that even if we want to transition to adult congenital services, if they don't have insurance, it's not so easy to get into those services. I know that I work in a hospital that is pretty much a safety net hospital for children. So in other words, if the kids come to the ER, if they have congenital disease, we take care of them. Whether they have insurance or not, well, eventually they'll get CCS. But the adults, I've heard many times, if they don't have insurance, they don't come to your clinic. They can't get in. And there's been more than once when I've talked about developing an adult congenital heart service, the comment from a chief of a division in adult cardiology would say, there's no money in it. So I know that clearly there are finances that are sort of not spoken upfront, but behind the scenes, there's the recognition that because there's not a profitability, there's just less effort, less emphasis, less resources put into it. And again, I think that the adult congenital heart is most vulnerable of the congenital heart patients.
And I think that's going to come back to some even, political stuff like the insurance for pre-existing condition. For example, like if that were ever to go away and it used to not be available, then patients were just not coming to care, because they couldn't afford it. And so, I think even, at a political level, I think this needs to escalate. These patients need to get care. These patients need to be able to transition from a pediatric facility after they lose their insurance. They need to be able to transition to adult care so that we're not seeing that. And that's a disparity in socioeconomic and in race and a lot of other things. So.
Yeah.
All right. I want to ask a provocative question because I think this is kind of interesting. So I'll try to simplify it as much as I can. So let's just maybe talk about PDA closures in premature infants. Okay. We've acknowledged that there are lots of reasons why there are healthcare disparities. And one of those is that there are a number of states, which Holly, I thought you did a great job of highlighting in your paper about, I think there's 14 states or something that don't even have congenital heart programs. So here's my question. We ourselves have resources. Should we be taking some of what we do on the road? And should we be getting out there into these smaller communities and doing things for them? One of the questions that I frequently get asked, and like I said, I'm trying to, I guess, oversimplify this, but, can you bring your PDA closure show on the road? So can you come to Baton Rouge? Can you go to Lafayette? Can you go to Shreveport? And I'm just curious, for some of these patients that, are out there in the community and don't have a lot of resources, should we be doing some procedures as teams in the community?
That's a great question. Yeah.
Oh, sorry. Go ahead. Well, I was just going to mention, Frank, a recent discussion that we just had through Think Tank was talking about regionalization of care. And this idea is the opposite, which is very interesting to think about. Certainly, Ivory, I think that when we consider, I think it's 8 states that do not have any interventional procedure capability. 14 states have just one. I think that's how it breaks down. We do have to think about, do we provide excellent care as we put our show on the road, so to speak. And one thing that I always worry about is that when we do these things, are we providing the same type of care, not just providing care in general? I do think if we have a way in which we can provide spectacular care in a mobile fashion, providing a team approach, that certainly is something that is worthy to pursue. But I think if we create disparities in ability because maybe we're limited with our resources at that institution, that then also provides another thing to question.
You know, you brought up something, Ivory, that I've been thinking a lot about. That has to do with, it actually goes in line with the last question I wanted to throw out to our panel, which is, what can we do? What can we do individually as part of our institution? And what are some of the systemic changes that can happen to improve this? And yes, if they can't come to us, can we go to them? And that certainly is one way. I definitely think that with the COVID pandemic, one of the silver linings that actually helped us to improve our telemedicine services. I know that every center now has that, whereas prior to this, not that many centers had that. So at least that gave us an opportunity to reach out to people who are far away and at least triage to say, you need to come in, right? So there's definitely some ways to improve the healthcare delivery. Now, whether they can physically get there for various reasons is another story, but certainly there are ways we can improve reaching out, especially to the rural community. Where I work up in Northern California, where there are huge swaths of rural areas where people actually have to drive a long way to get to us. So I totally understand the hardships of that. But I think that I want to throw out to you guys, any thoughts on what can we do individually? What can we do within our institutions? And what are some of the systemic things that we can do to improve this?
So I think that all of these are great ideas, and reaching out, like you're saying, Ivory, and is great. But who's going to fund this? So it actually is going to go back to funding. Is there a way that we can put forth government funding to allow us to have, we can do telemedicine for patients and then have a mobile cart that goes out to do diagnoses of these patients, have funding so that we can transport these patients, by whatever ambulance or by flight to a center that can take care of them. The whole regionalization or centralization of care, that's a huge topic, but without funding, with no infrastructure, that will not work, because it only takes the place that can do the best care further away from these places. So I would say the most important thing is to figure out a way to get funding to make sure patients can maintain insurance even with pre-existing conditions. And that's not something that, we as a community, a pediatric interventional community can take care of. This needs to go higher, and it needs to get attention.
I think that first thing that we can do is to get involved in advocacy. As Ivory mentioned, the adult group really does a good job with this. And I think the interventional community in the congenital space, we really just don't. I think one way to do it is local politics. State politics is something we have to get involved and advocate for our patients. And then I think the first step every single one of us need to do is to understand the disparities at your institution, because I guarantee you that there are low-hanging fruits that we can start to think about. Ivory mentioned some of the, taking care of the individuals in our state or moving around in the state, but maybe even just thinking about barriers to getting our patients here. I know in the state of Georgia, we can improve our Medicaid transportation. We can improve, scheduling times for these patients to come in at different times, not asking our families to do 4 different appointments for one procedure. And making it easier for them to do so. So I think there's a lot that we can do that's low-hanging fruit, but the biggest thing that we need to do is to get ourselves moving as a community and bind together and really go forth with advocacy at a government level.
With that, I think that was a great ending, Holly. I think we're at the end of our session. So thank you, everybody, for participating in this. And I'm sure we're going to be talking about this more in the future. So thanks, everybody.
Thank you.